A very good afternoon, everyone. If you could share my voice and see the screen properly, type yes on the chat box. If you could share my voice and see the screen properly, type yes on the chat box. One whomsoever present here to acknowledge faster. If you could share my voice and see the screen properly, type yes on the chat box so that we can able to proceed. So speaking about it, today we are going to talk about the, ophthalmology. Today we are going to talk about ophthalmology, quite one of the important subject. And apart from that, you have a few other things in the ophthalmology we're going to discuss. We're going to discuss only the high yield area. So speaking about the high yield area of ophthalmology, so the main area of interest is like trachoma, and you have your cataract, and you have your glaucoma, and then you have your anatomy and physiology of eye. Anatomy and physiology of your eye, which is quite important in terms of your ophthalmology. So speaking of the ophthalmology, so the very first one is your, the structure of your eye. The very first one we are going to talk about is your structure of your eye. So what are the structures of your eye which you are having? What are the structures of your eye which you are having? So we're going to discuss about that people first. So we are having the outermost layer. So we are having the outermost layer here. So on the structure of eye, this outermost layer is so-called as cornea. The outermost layer here is so-called as cornea. Speaking about the cornea, the thickness of cornea is 500 to 600 500 to 600 microns. Okay, let me put it here clearly. There is some things which is going on. Okay. So here you have a cornea. So speaking of a cornea, the thickness of the cornea is 500 to 600 microns, where the central part is the thinnest portion of your cornea, people. Where the central part is the thinnest portion of your cornea. One second. Pencil is not working. There is something wrong with this images. Let me check it out. 1 second. Okay. So the first area we are going to talk about is your structure of your eye. Okay, it's not working. Let me put this up in the notes. 1 second. Okay, if you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box. I want whomsoever present here to acknowledge faster. If you could hear my voice and see the screen properly, type yes on the chat box. Can't see the screen. Okay, 1 second. Nope. Because there is something wrong with the screen. Okay, I want whomsoever present here to acknowledge faster. If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box. I want whomsoever present here to acknowledge faster. If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box. Okay, very good. So today we are going to talk about the ophthalmology. Don't want to waste much of your time, people. So we proceed with the ophthalmology on the structure of eye. So speaking about the structure of eye, the outermost layer is the cornea, where the thickness is 500 to 600 micro. Thickness is 500 to 600 microns, and the thinnest part of cornea is the central part. Central part is the thinnest part, people. And apart from that, the corneal thickness is measured by pachymetry, and the corneal curvature is measured by keratometry. Very, 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 very important MCQ. Corneal thickness is measured by your pachymetry, while corneal curvature is measured by your keratometry. So the outermost layer is your cornea, and next to the cornea, behind the cornea, you are having the stir layers, that is your choroid. Inside the cornea, you are having a choroid, and in between your choroid and the cornea, you are having a vortex veins. In between your choroid and the cornea, we are having a vortex veins, and the choroid is meeting with the ciliary body. The choroid is meeting with the inner ciliary body, and the point where the choroid meets with the ciliary body is so called as ora serratia. Okay, the point where the ciliary body meets with the choroid is so called as or the retina meets with the ciliary body is so called as ora serratia. And then you have the ciliary body. Speaking about the ciliary body is of two areas we can able to mark the ciliary body. So it contains a two important area. One is your pars plana, one is your pars plana, and another one is your pars plicata. One is your pars plana, and another one is your pars plicata. Among that, the pars plicata is can produces your aqueous humor. Pars plicata produces your aqueous humor. Okay. So speaking about that, you are having aqueous humor and a vitreous humor, and then from the ciliary body, you are having a lens which is going to attach to that, and then from the in front of the lens, you are having an iris. So thinnest part of your iris is so called as root of iris, and apart from that, iris is also called as the goddess of rainbow. Iris is also called as the goddess of rainbow. Okay, because it gives a color to your eye. So that's why iris is also called as the goddess of rainbow. Okay, so outer layer cornea, inner layer retina. Retina contains a choroid, and where the point retina gets attached to the ciliary body is ora serratia, and then the ciliary body contains the pars plana and the plicata. Among that, pars plicata will produces your aqueous humor, and then in front the ciliary body is getting attached with the lens, and in front of the lens you are having an iris, and this iris is a thinnest part of the iris is a root of iris, where it is so called as a goddess of rainbow, where it is so called as a goddess of rainbow. And apart from that, behind the lens you are having a vitreous humor. In front of the lens you are having an aqueous humor. In front of the lens you are having a aqueous humor. And between your lens and your iris, you are having your posterior chamber. Between your lens and your iris, you are having your posterior chamber. Let me highlight it here, posterior chamber. And in front of the iris, you are having your anterior chamber. And the depth of the anterior chamber is 2.5 mm, 2.5 mm. And apart from that, behind the lens, you're having a macula. Behind the macula, you're having a choroid. And then behind the retina, you're having an optical disc and optical disc to fovea centralis, where the diameter of fovea centralis is 1.5 mm. And this fovea centralis is the most sensitive area of your eye. What is the most sensitive area of your eye? Which is your fovea centralis, where the diameter of your fovea centralis and the optic disc is 1.5 mm. So outermost layer is cornea, and behind the cornea you are having a sclera. Thinnest part is where the rectum, where rectus is attached, and behind and above the sclera, you are having a conjunctiva, which is a thin transparent layer. And apart from that, the junction where the cornea and the sclera meets is so called as limbus. So outermost layer of your eye is a cornea. Thickness of cornea is 500 to 600 microns, and the thinnest part is the central part. Okay, and corneal thickness is measured by pachymetry, while curvature is measured by keratometry. And behind the cornea, you are having a sclera, and the junction where the cornea and the sclera meets is your limbus. And the sclera, thinnest part of the sclera is where the rectus is attached, and above the sclera, you are having a thin transparent layer called as conjunctiva. And behind the cornea, you are having inside the cornea, you are having a retina where it contains a choroid, and the retina, the point where the retina meets the ciliary body is your ora serratia. And then the ciliary body is containing two parts. One is your pars plana and another one is your pars plicata, which produces aqueous humor. And ciliary body attaches with the lens, and in front of the lens you are having an iris, which is so called as a goddess of rainbow, where the thinnest part is the root of iris. Okay, and in between your lens and your iris, you are having this posterior chamber, and in front of the iris you are having an anterior chamber. And behind the lens you are having a macula, choroid, optic disc, and fovea centralis. And among that, fovea centralis is the most sensitive area, while the diameter of the fovea centralis is while the diameter of your fovea centralis is 1.5 mm. 1.5 mm. Okay, so these are the things you have to know in terms of your anatomy of your eye, people. And apart from that, you need to know about the power, I mean, or the refractory index of the each organelle. Refractory index and power of the each organelle. So speaking about the aqueous humor, refractory index is 1.34, and for cornea it is 1.37, and for lens it is 1.39, and for lens it is 1.39. And apart from that power, cornea plus 43 to 45 D, and lens it is plus 15 to 17 D. And for an overall eye, it should be the combination of cornea and lens, so it contains a 58 to 60 D. 58 to 60 D. And the power of the eye at birth is plus 2.5 D. Plus 2.5 D. So these are the important powers and refractory index. What is the refractory index of aqueous humor? 1.34, cornea 1.37, lens it is 1.39. And power, cornea it is plus 43 to 45, and lens it is plus 15 to 17. Overall, it should be plus 58 to 60 D. Okay, overall it should be plus 58 to 60 D. And axial length of the eyeball is 24 mm. Axial length of the eyeball is 24 mm. And the normal intra-optic pressure or intraocular pressure is 10 to 21 mm of Hg. 10 to 21 mm of Hg. And intraocular pressure is measured by tonometry. We are having two types of tonometry. One is your Feautres, and the another one is your Goldman tonometry. Okay, so intraocular pressure, it is tonometry, and corneal curvature, it is a pachymetry. Sorry, it is a keratometry. Corneal thickness, it is a pachymetry. Okay, pachymetry for corneal thickness, curvature keratometry, intraocular pressure, we are using a tonometry. Apart from that, embryological origin of your eye, pretty important one. You have to remember in terms of your embryological origin. So speaking about the embryological origin, we are having a surface ectoderm where you may see the lens, conjunctiva, and cornea. Lens, conjunctiva, and cornea are coming from the surface ectoderm. And neuroectoderm, smooth muscles of iris, retina, and optic nerve comes from the neuroectoderm. Then you are having a mesoderm where you may see the extraocular muscles, choroid, and sclera. Extraocular muscles, choroid, sclera originates from the mesoderm, while smooth muscles of iris and retina are neuroectoderm. Lens, conjunctival epithelium, and corneal epithelium are surface ectoderm. And apart from the neural crest cells, where you may see there is a corneal endothelium, trabecular meshwork endothelium, ciliary muscle, and keratocytes are all comes from the neural crest cells. Okay, keratocytes, corneal, trabecular, and you have this, the ciliary muscles are coming from the neural crest cells. Okay, so surface ectoderm, lens, conjunctiva, and cornea. Okay, neuro, smooth muscles of iris, retina, and optic disc. Mesoderm, extraocular muscle, choroid, and sclera. while your neural crest cell, keratocyte, corneal endothelium, trabecular meshwork endothelium, and ciliary body. Okay. Apart from that, you are having a visual acuity. 6 by 6, the numerator indicates different distance between the patient and the chart as numerator, and distance where the normal person can read the same as the denominator. Distance where the normal person can read the same as the denominator, and distance where the distance between the patient and the chart is your numerator. So what are the important ophthalmologic chart which you have to know? What are the important ophthalmologic chart which you have to know? One is your Tellens chart. The most preferable chart is your Tellens chart, where the distance should be 6 meter. And for illiterate, you can use a Landau's ring. For illiterate, you use a Landau's ring. And for preschool children, you can use a Allen's chart or Lee's chart. And for a preverbal children, you can use the optokinetic nystagmus. Optokinetic nystagmus. Okay, apart from that, how do you call that there is a lack of a vision? So whenever the person is having a decreased or impaired perception of light, whenever the person is having a impaired perception of light, then it is a irreversible blindness. Then it is a irreversible blindness. When do you call it as a irreversible blindness? Whenever the person is having a impaired a perception of light. Apart from that, color vision. So speaking about the color vision, the test uses for the color vision is Iscaris chart and FM100 Q test. Iscaris chart and FM100 Q test we uses. And apart from that, color vision, for a red color vision lack, a patient is having a protanopia, green deuteranopia, blue tritanopia. So red is protanopia, green is deuteranopia, and blue is tritanopia. Okay. Apart from that, the measurement of the visual field is perimetry. Measurement of your visual field is perimetry. So technically, you are having a 4 types of visual field. One is your superior field. Another one is your inferior field. And lateral one is your temporal field. And medial one is your nasal field. Okay. Medial one is your nasal field. So what are the 4 types of visual field we are having? Superior field, inferior field, our lateral one is so called as temporal field, and medial one is so called as nasal field. Okay, apart from that, absence of lens, that is a aphakia, where you may see the jet black pupil, where you may see the jet black pupil, and the type 2 Purkinje fibers are there in the terms of your aphakia. Jet black pupil and the type 2 Purkinje fibers are seen in aphakia. Then apart from that, you are having a refractive error. Speaking about the refractive errors, it could be of a myopia and a hypermetropia people. Okay, myopia and hypermetropia. What is a myopia? The light should be focused on front of retina. The light should be focused on front of retina is myopia. Light should be focused on back of retina is hypermetropia. Okay, light focused on front of retina is myopia. Light focused on back of retina is hypermetropia, while you have a concave lens is used in terms of myopia and convex lens is used in terms of hypermetropia. Okay, concave lens is used in terms of myopia, while convex lens is used in terms of your hypermetropia. Then you are having a far vision which is affected in myopia, while in the case of hypermetropia, both near and far vision is affected. And you may see the faster fuse spot on macula, and lacular crack on retina, and lattice degeneration post staphyloma you may see. Okay, lattice degeneration post staphyloma you may see in the case of myopia. What are they? Faster fuse spot on macula, lacular crack on retina, lattice degeneration post staphyloma you may see. Apart from that complication, retinal detachment and the primary open angle glaucoma. Open angle glaucoma is a complication of myopia. Open angle glaucoma is the complication of myopia. And apart from that, hypermetropia, you may see the silk short retina people. You may see the silk short retina and pseudopapillitis. Silk short retina and pseudopapillitis, you may see it in the case of your hypermetropia. Okay, so far you can get the PDF while the admin will drop you the link in a moment so that you can able to download the PDF through that link. Okay. So now apart from that, you are having a complication. So myopia, what are the complications we have seen? Open angle glaucoma and retinal detachment. While in the case of hypermetropia, angle closure glaucoma and early presbyopia, you may see. Early presbyopia, you may see. Apart from that, both we can able to do the treatment of choice. Treatment of choice is either you can give the spectacles, or you can do the radical keratotomy, or you can do the intacs or PRK or LASIK, or you may see that there is a clear lens extraction, or you may see the phakic intraocular lens. Phakic intraocular lens you may see. Okay. Apart from that, for a treatment of hypermetropia, spectacles, conjunctive keratoplasty, that means a holmium YAG laser will be used. Hyperopic LASIK will be there. Hyperopic LASIK will be there, and phakic IOL will be there. Okay, and phakic IOL will be there. So you're having a refractive index. So myopia and hypermetropia. So speaking about the myopia and hypermetropia, so the first, what are the things you have to remember? Myopia means light will be focused on front of retina, while hypermetropia means light will be focused on back of retina. And apart from that, you are having a concave lens used in myopia, and hypermetropia, you may have a convex lens used. So where do we use the convex lens? Where do we use the convex lens, people? Myopia or hypermetropia? Where do we use the convex lens? Hypermetropia. Concave lens? Myopia. Silk short retina is seen in. Silk short retina is seen in hypermetropia. Foster fused spot on macula is seen in myopia. Foster fused spot on macula is seen in myopia. Lattice degeneration post staphyloma is seen in myopia. Open angle glaucoma is a complication of myopia. Angle closure glaucoma is the complication of hypermetropia. And early presbyopia is a complication of hypermetropia. Retinal detachment is a complication of myopia. Aphakia means absence of lens, where you see jet black pupil. Allen's chart is used for preschool children. Landau's ring is used for illiterate people. FM100 hue test is used for color detection. And apart from that, DAPS, impaired perception of light, is so called as permanent blindness. Permanent blindness. So these are the important things where you have to know about the basics of your ophthalmology, people. And speaking about the next important area where you may have to see the cataract. So cataract, what is a cataract? Lens and the capsule will undergo opacification, is so called as cataract. So oldest component of lens is your nucleus, and most cataract is the most common cause of blindness. Cataract is the most common cause of blindness. So we classify the cataract based upon three things. One is your location, etiology, and maturity, people. So we classify the cataract based on location, etiology, and maturity. So speaking about the location, where the location, if the location is the nucleus, then you may see the nuclear cataract. And if the location is the cortex, then you may see the cortical cataract. And if the location is in the capsule, then capsular cataract and subcapsular cataract. So based upon the location, nuclear, cortical, capsular, and subcapsular. Among that, you may see the index myopia in the nuclear cataract and index hypermetropia in the cortical cataract. Very, 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 very important MCQ. Index myopia is seen in nuclear cataract. Index hypermetropia is seen in cortical cataract. And apart from that, posterior subcapsular cataract is the one which is a more dangerous one. Most dangerous cataract is your posterior subcapsular cataract, and it produces a glare at a nodal point. It produces a glare at a nodal point. Okay. So quite an important one. And apart from that, etiology. So speaking about the location, we studied 4 cataract. What are they? Nuclear, cortical, capsular anterior posterior, and subcapsular anterior posterior. Most dangerous one is subcapsular anterior posterior. And index hypermetropia is seen in cortical. Index myopia is seen in nuclear cataract. Index myopia is seen in nuclear cataract. Then you are having an etiology based classification based on the etiology. Speaking about the classification based on the etiology, first one is a senile cataract, people, which is the most common form. and age-related cataract. What is the most common cataract? Senile cataract, which is a age-related cataract. One of the classical MCQ that you should not miss. Okay. And apart from that, congenital cataract. So congenital cataract is associated with the three things. Congenital cataract is associated with the three things. Either an infection or a vitamin D def, or maybe a history of consumption of thalidomide, or the history of consumption of thalidomide or vitamin D associated cataract, or the patient is associated with the infection, especially rubella infection, especially rubella infection. So congenital cataract is basically divided into two types. One is your zonular cataract, another one is your rubellar cataract. Zonular cataract and rubellar cataract are the two types of congenital cataract we are having. Zonular cataract means only a specific zone will be involved associated with the vitamin D def, and you may see spokes of wheel appearance. Classical MCQ people. You see what type of appearance in the zonular cataract? Spokes of wheel appearance you may see. Index myopia is seen in nuclear, and index hypermetropia is seen in. Index hypermetropia is seen in cortical. And apart from that rubellar cataract, you may see two things. Nuclear pearly white cataract you may see, and you may also see the salt and pepper retinopathy. You may also see the salt and pepper retinopathy in the rubellar cataract, and nuclear pearly white cataract you may see it in the rubellar cataract. Then you may have a zonular cataract. So speaking about the zonular cataract, there will be a specific zone which is affected and vitamin D will be deficient, and you may see the spokes of wheel appearance, people. You may see the spokes of wheel appearance. So apart from that, as we said, based on the etiology, most common cataract is age-related cataract, congenital, thalidomide consumption, or maybe vitamin D or rubella infection. Salt and pepper retinopathy is seen in rubellar cataract. Spokes of wheel appearance is seen in zonular cataract. Then you are having a developmental cataract, which is due to the trisomy 21. One of the classical example is trisomy 21. Then you are having a traumatic cataract. So speaking about the traumatic cataract, which is a rosette cataract, where you may see the osseous ring, that is an imprintation of your iris on your lens, that is so called as osseous ring, and commonly occurs in cortex of lens, and commonly occurs in posterior subcapsular cataract. Commonly occurs in cortex of lens and posterior subcapsular cataract. Then complicated cataract, you're having a I used to remember with the mnemonic of rigid as a complicated cataract causes. It could be a retinitis pigmentosa. It could be a retinitis pigmentosa, or inflammation, or glaucoma, or intraocular tumor, or degenerative diseases of eye. So what are the complications of your, what are the causes of your complicated cataract? Rigid is a causes, retinitis pigmentosa, inflammation, glaucoma, intraocular tumor, degenerative diseases of eye. Then you are having a slit lamp examination shows breadcrumb appearance with the polychromatic luster, people. Breadcrumb appearance with polychromatic luster. Then you are having a metabolic one. So speaking about the metabolic one, we are having a named cataract, diabetes, snowflake cataract, galactosemia, oil drop cataract, and Wilson disease, sunflower cataract, myotonic dystrophy, Christmas cataract. Okay, Christmas tree cataract is seen in myotonic dystrophy. Wilson disease, you may see the sunflower cataract. Galactosemia, you may see the oil drop cataract. And diabetes, you may see the snowflake cataract. So these are the important metabolic type of cataract. And you are having a heat or radiation associated with the posterior subcapsular and drug-induced cataract. What are the drugs that can able to induce a cataract are? One is your ACHE inhibitors, acetylcholine esterase inhibitor, myotex, chlorpromazine, busulfan, chloroquine, amiodarone, gold and iron metals. So these are the important ones. ACHE inhibitors, myotex, chlorpromazine, busulfan, chloroquine, amiodarone, gold and iron. Amiodarone, gold and iron are the drug-induced cataract. Okay, drug-induced cataract. Apart from that, radiation, posterior subcapsular, And metabolic, 4 causes: diabetic, snowflake cataract, galactosemia, oil drop cataract, Wilson disease, sunflower cataract, myotonic dystrophy, Christmas tree cataract. Complicated one, rigid, slit lamp examination shows breadcrumb appearance or polychromatic lustures. Okay. And apart from that, traumatic cataract, you may see rosette cataract, Vossius ring, or rosette cataract and Vossius ring. And if they are specifically asking you, if you don't see both of them in the option, try to shoot posterior subcapsular cataract. Try to shoot the posterior subcapsular cataract. So these are the based upon the etiology. Based upon the etiology, the cataract has been classified into nearly 8 types. Nearly 8 types, and all of the subtypes have been discussed here. Then maturity cataract, maturity onset cataract, where you may see early incipient, where you may see the small dot of opacification, and you may see the diplopia along with the scattering of light, then immature cataract, enlargement of opacification, lens appears to be in a gray or iris shadow. Okay. Mature cataract, aquaparine opens for a long time, fluid accumulates in the lens will get bulges, posterior chamber will close, and then intraocular pressure will be raised due to the aqueous humor accumulation. That's the mechanism behind the mature cataract. And you are having a hypermature, Morgagnian and sclerotic. Morgagnian is a soft lens, while the sclerotic is a hard lens. Okay, Morgagnian is a soft lens, while the sclerotic is a hard lens. Then speaking about the cataract surgery highlights. So when do you do the surgery, people? So for timing, bilateral congenital, 4 to 6 weeks of birth, unilateral congenital within a days of birth, and intraocular lens implantation, we have to wait till the baby gets 2 years of age. Okay, you have to wait till the 2 years of baby gets 2 years of age. And most common complication is PCO, that is a posterior capsular opacification, where the treatment is Nd:YAG laser. Okay, Nd:YAG laser we can use for the capsulotomy to remove the capsular opacification. And most serious complication is your endophthalmitis, and cystoid macular edema after surgery is so-called as Irvin-Goss syndrome. And apart from that, we are having a ICCE, ECCE, SICS. Apart from that, what are the ICCE? Removal of lens and capsule is the ICCE. ECCE is IOL implantation in the bag. And apart from that, SICS, sutureless small incision cataract surgery is SICS. And apart from that, phacoemulsification, where you use a titanium and capsulorhexis is must. Okay, titanium needle is used, while the capsulorhexis is must. These are the cataract surgery highlights. So bilateral congenital cataract, how long you have to wait? 4 to 6 weeks of birth. Unilateral congenital cataract, how long you have to wait? Within a days of birth. And IOL implantation, more than 2 years. Okay, most common complication is posterior capsular opacification. Treatment of choice is Nd:YAG laser. Okay, and most serious complication is endophthalmitis. Cystoid macular edema after the cataract surgery is so called as Irvin-Goss syndrome. Okay, which is so called as Irvin-Goss syndrome. So these are the important things you have to know in terms of your cataract, people. So basics and the cataract are the important areas where you may get at least 2 to 3 questions in these 2 areas. Okay, where you may get at least 2 to 3 questions in this 2 areas. So one is your, so speaking about that, so we revise the basics and your, your cataract. So speaking about the cataract, so what is the, can we divide the cataract based on the 3 areas? One is your location, etiology, and maturity. So what are the cataract, what are the types of cataract we are having for the location? Keep your hands on the keyboard, people, and start typing it. What are the types of cataract we use as for the, it comes under the classification based on the location. 4 types, what are they? Nuclear, cortical, capsular, subcapsular. Most dangerous one is, what is the most dangerous form of your cataract? Posterior subcapsular cataract. Index myopia is seen in nuclear cataract. Index hypermetropia is seen in cortical cataract. And apart from that etiology, we classify the etiology based upon the eight types. One is your senile cataract, which is the most common cataract. Apart from that, you have a salt and pepper retinopathy is seen in. Rubellar cataract, spokes of wheel appearance is seen in. Spokes of wheel appearance is seen in. Zonular cataract, rosette cataractus, traumatic cataract, Washer's ring is seen in. Traumatic cataract, breadcrumb appearance or polychromatic luster on the slit lamp examination is seen in. Complicated cataract, snowflake cataract is seen in. Snowflake cataract is seen in. Diabetes, oil drop cataract is seen in. Oil drop cataract is seen in. Galactosemia, sunflower cataract is seen in. Wilson disease. And Christmas tree cataract is seen in. Myotonic dystrophy. Christmas tree cataract is seen in myotonic dystrophy. Heat or radiation induced cataract is associated with posterior subcapsular. Posterior subcapsular. Drug induced ones are, what are the drugs which can able to cause the cataract? ACE inhibitor, acetylcholinesterase inhibitor, Myotex, chlorpromazine, busulfan, chloroquine, amiodarone, gold and iron. Gold and iron. Apart from that, Morgagnian cataract, you may see what type of lens? Soft lens. Sclerotic cataract, you may see what type of lens? Hard lens. Okay. Most common complication of cataract surgery is PCO, posterior capsular opacification, treated by Nd:YAG laser capsulotomy. Okay, most serious complication is endophthalmitis. Okay, titanium needle is used in phacoemulsification. Phacoemulsification. Silk shot retina is seen in hypermetropia. Hypermetropia. Okay, what type of cataract surgery is the in the back surgery? What type of cataract surgery is the in the back surgery, which is your ECCE, which is your ECCE. So these are the important MCQs related to the cataract. And this cataract page is one of the page where you have to read 1 hour before the exam. You have to take a printout and you have to sit in the, like in your car or somewhere and eating your lunch. That's the time you read one paper and important papers. This is one among the papers to revise it and make sure you answer it right. Next is a glaucoma, primary open angle and primary angle closure glaucoma. Primary open angle and primary angle closure glaucoma. So gene defect is myocilin gene. Gene defect is myocilin gene, which is on a chromosome 1q, and optineurin gene, which is on chromosome 10p. And asymmetry of cup disc ratio in the primary open angle glaucoma is more than 0.2. And what are the changes? You may see it in the primary open angle glaucoma. That is your vertically oval cupping, bionetting sign or splinter hemorrhage, Brand's hemorrhage or beanpot cupping, laminar dot sign you may see. Laminar dot sign you may see. Apart from that, visual field defect, isopter contraction, cedral scotoma, bijorum or arcuate scotoma, Rowan central nasal step, tubular vision, you may see it in the primary open angle glaucoma, where the treatment of choices, laser trabeculoplasty and trabeculectomy is the gold standard of choice. Trabeculectomy is the gold standard of choice. And the primary angle closure glaucoma, stages, latent one, colored halos, treatment of choices, NDR, iridotomy, intermittent, stage of constant instability, where the event of mydriasis will be seen. And apart from that, what are the drugs which we can able to give for the glaucoma to decrease in the aqueous humor secretion or decrease in aqueous outflow, increase in aqueous outflow. So aqueous outflow could be increased by either a trabecular outflow or uveosacral outflow. Trabecular outflow or uveosacral outflow. So increased trabecular outflow is associated with the myotics and alpha-2 agonists. Myotics and alpha-2 agonists such as pilocarpine, physostigmine, dipivefrin, all those things are the increased trabecular outflow. They asked this as a question once in FMGE. Okay, pilocarpine mechanism of action in terms of glaucoma is increase in trabecular outflow. Increased uveosacral outflow was prostaglandin analog, latanoprost and bimetoprost and so on. Okay, trabecular outflow increase, myotics and alpha-2 agonists, uveosacral outflow increase, latanoprost and bimetoprost. Okay, then you are having a decrease in aqueous humor secretion where we are using a beta blockers, alpha-2 agonists, and CAI. And CAI. And CAIs are your acetazolamide, dorzolamide, and brinzolamide, and so on. Acetazolamide, dorzolamide, and brinzolamides, and so on. While alpha-2 agonists are brimonidine and apraclonidine. And apart from that, beta blockers are cardioselective and non-cardioselective. Cardioselective beta blockers used for the glaucoma is bitoxolol and levobitoxolol, while non-cardioselective are timolol, levobunolol, and cartiolol. Timolol, levobunolol, and cartiolol. Okay, then you are having a retinal detachment. So, which is your rhegmatogenous, sudden painless loss of vision is rhegmatogenous, which can cause a myopia and trauma. Exudative, sudden painless associated with the malignant melanoma of choroid, where the treatment of choice is enucleation. And tractional retinal detachment, slow painless loss of vision associated with the diabetes mellitus and vitrectomy. Diabetes mellitus and vitrectomy is tractional. Sudden painless loss of vision associated with malignant melanoma of choroid, which is exudative retinal, and sudden painless loss of vision, which is associated with the myopia or trauma, that is your rhegmatogenous retinal detachment. Rhegmatogenous retinal detachment. Apart from that, CRAO. So speaking about the retinal disorders, retinal detachment we have seen. Now next is a CRAO, central retinal arterial occlusion. What are the things you need to remember in terms of central retinal arterial occlusion? Whenever, what are the things it should come into your brain? Sudden painless loss of vision, white retina, cherry red spot on macula, cherry red spot on macula, box carrying or cattle tracking appearance with Holland-Host plague. Box carrying or cattle tracking appearance with Holland-Host plague is CRAO. Cherry red spot on macula, CRAO. Very, 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 very important. Okay, then you are having a CRVO. So dot blot or flame-shaped hemorrhage, you may see it with the CRVO. And rubeosus iridis, you may see it with the CRAO, where you may see it in the ischemic variety, especially 100th day glaucoma and blood and thunder. Fundus are the ischemic varieties of your rubeosus iridis, which is your component of CRVO. So cherry red spot on macula, cattle tracking appearance, CRAO. And blood and thunder fundus, dot blot hemorrhage, flame-shaped hemorrhage, or 100th day glaucoma, CRVO. CRVO. So retinal detachment we have seen, CRAO, CRVO we have seen. Next is a retinitis pigmentosa. Speaking about the retinitis pigmentosa, which is associated with the night vision, night blindness, or nyctalopia. And you may see the tessellated appearance on fundus, tessellated appearance on your fundus, and you may see there is a triad of your retinitis pigmentosa. One is your bone spicule pigmentation, waxy pallor of optic disc, and arteriolar attenuation. Bone spicule pigmentation, waxy pallor of optic disc, arteriolar attenuation, and ring scotoma. You may see the ring scotoma in retinitis pigmentosa. You may see the ring scotoma in retinitis pigmentosa. And what are the syndromes associated with this retinitis pigmentosa are pretty important. Basen-Konzweig syndrome, Repsom's disease, and Bardet-Biedl syndrome, Usher syndrome, Cockayne syndrome, Hart syndrome, and Friedreich's ataxia. Basen-Konzweig syndrome, Repsom's disease, Bardet-Biedl syndrome, Usher syndrome, Cockayne syndrome, Harp syndrome, and Friedreich's ataxia are the things which is associated with the retinitis pigmentosa. Then you are having a retinoblastoma. When we are having a retinoblastoma, where the like a cancer of your immature cells of retina, you may associate it with the retinoblastoma. RB gene mutation, which is a 13q14 classical MCQ. Okay, RB gene mutation, Metastasis is via optic nerve. Treatment of choice is enucleation. Okay, enucleation. So retina, we have done. So retinal detachment, 3 types. What are they? Rhegmatic, exudate, and tractional. Keep your hands on keyboard, people. What is the rhegmatic one? Sudden painless loss of vision associated with myopia and trauma. Exudative, sudden painless loss of vision associated with malignant melanoma of your choroid. While tractional, sudden painless loss of vision associated with DM and vitrectomy. CRAO, what are the things you have to remember? Cherry red spot on macula, cattle tracking appearance with Holland-Host plaques. Holland-Host plaques. CRVO, what are the things you have to remember? CRVO, what are the things you have to remember? Dot plot appearance or flame-shaped hemorrhages. And you may see the ischemic variety with the 100-day glaucoma, blood and thunder fundus. You may see it with the blood and thunder fundus. Then you are having a retinitis pigmentosa, where you may see the nyctalopia, tessellated appearance on fundus, anterior attenuation, bone spicule pigmentation, and waxy pallor of optic disc. And you may see there is a ringed scotoma. Ringed scotoma is seen in retinitis pigmentosa. Retinoblastoma, RB gene mutation, 13q14. Location of metastasis is via optic nerve. Tumor of your immature cells of retina. Tumor of your immature cells of retina. Then you are having a uveitis. Anterior uveitis is your iridocyclitis. Anterior uveitis is your iridocyclitis, where you may see aqueous flare, aqueous cell positive, HLA-B27 association, Koyapi and Busaka nodules. Very, 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 very important MCQ. Koyapi and Busaka nodules, Al's triangle inflammation, rubeosis iridis, and annular synechiae. Annular synechiae you may see. So iridocyclitis, aqueous flare, aqueous cells will be positive. HLA-B27 association, Koyapi and Busaka nodules are seen in anterior uveitis. Koyapi and Busaka nodules are seen in anterior uveitis. Then you are having a posterior uveitis, where you may see the choroiditis, retinitis, and vasculitis. Okay, choroiditis, retinitis, vasculitis is associated with the posterior uveitis. Apart from that intermediate one, floaters with a blurred vision, snowball opacities is seen in intermediate uveitis. Very, 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 very important MCQ. Snowball opacities is seen in intermediate uveitis. Snowball opacities are seen in intermediate uveitis. Okay. Then, apart from that, what are the special uveitis we are having? One is your CMV retinitis, where you see the pizza pie or cottage cheese or tomato ketchup fundus. Tomato ketchup, cottage cheese, or pizza pie appearance is seen in CMV retinitis. And Fuchs heterochromic iridocyclitis, you may see the Amsler sign positive. Fuchs heterochromic iridocyclitis, you may see the Amsler sign positive. And sarcoidosis, you may see the candle wax appearance or candle wax dripping sign, along with the Landers sign, Onchocerciasis, river blindness, and toxoplasmosis, headlight on fog appearance, satellite lesion. Classical MCQ. Headlight on fog appearance, satellite lesion. Snowball opacities, you may see it in the intermediate uveitis. So Fuchs heterochromic iridocyclitis, what sign you may see? Amsler sign. Okay, candle wax dripping sign is seen in sarcoidosis. And Landers sign is positive in sarcoidosis. And headlight on fog appearance is seen in toxoplasmosis. Satellite lesion is seen in toxoplasmosis. And in snowball opacities is seen in intermediate uveitis. Koyapi and Busaka nodules are seen in anterior uveitis. These are the important things you have to know about the uveitis. So we have talked about the cataract, we have talked about the glaucoma, we have talked about the retinal disorders, and we have talked about this uveal disorder. Now we are going to talk about the cornea. There are 5 layers of cornea: anterior layer, Bowman's layer, collagen lamellae, descendant membrane, and endothelium. Descendant membrane and endothelium. Very, 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 very important MCQ. What is a stain we use for the cornea? Rose Bengal stain. What are the stains we use for the cornea? Which is your Rose Bengal stain. Another important thing, what are the named findings? You may see it in the cornea. Fleischner ring associated with the keratoconus. Fleischner ring associated with the keratoconus. Stalker's line, pterygium. Ferry's line, filtering bleb. Mutson-Stahli line, old opacity, Kaiser-Fleischner ring, Wilson disease, Krukenberg spindle, pigment dispersion syndrome. Krukenberg spindle is associated with pigment dispersion syndrome. Kaiser-Fleischner ring is associated with Wilson disease. Old opacity is associated with the Hudson-Stahli line. And filtering bleb is associated with the Ferry's line. Pterygium is associated with the Stalker's line. Keratoconus is associated with the Fleischner's ring. Keratoconus is associated with the Fleischner's ring. Oh, these are the important thing you have to know. Then you are having a conjunctivitis. So cornea was done. Important name the findings in cornea was done. Conjunctivitis. So bacterial conjunctivitis, mucopurulent discharge where you see the Staph aureus. Viral conjunctivitis, pink eye, anterior stromal infiltration you may see. And apart from that, angular conjunctivitis, Moraxella lacunata will be there. Treatment of choice is zinc. And vernal keratoconjunctivitis, also known as spring catra, associated with the stingy or ropey discharge. Maxwell-Leonstein, cobblestone papillae, Horner-Tranter spots will be seen. Horner-Tranter spots will be seen. Apart from that, you are having a safe strategy. Trachoma is for the safe strategy. We already studied that. What are the things you have to know in terms of your ophthalmology is Hall's line and Haber-Spitz. Hall's line and Haber-Spitz are seen in a trachoma, and safe strategy is followed in trachoma. Shortest acting mydriatic is tropicamide. Longest acting is atropine. Mydriatic but not cycloplegic is phenylephrine. Mydriatic but not cycloplegic is phenylephrine. Then you are having a WHO staging of xerophthalmia. XN staging is night blindness, where the patient have this type of vision. X1A, conjunctival xerosis, and Bitot spots are seen in X1B. Very, 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 very important MCQ. WHO staging of your xerophthalmia. WHO staging of xerophthalmia. X1B is your Bitot spot. X1A, conjunctival xerosis. XN, night blindness. X2, corneal xerosis. X2 is corneal xerosis. Apart from the trachoma, most common organism was a chlamydia trachomatis, we already knew. And Haber-Spitz and Hall's line, we already knew. And grading is grading. And strategy is safe strategy. We already studied about that. Okay. Apart from that, what are the important lines in the ophthalmology? Fleischner ring, keratoconus, and Ferry's line, filtering bleb, Stalker's line, pterygium, and Hudson-Stahli line, old opacity. We have already studied about that. Then you are talking about the keratitis. We are having a bacterial keratitis, which is a sterile, wet-looking ulcers with a distinct margin is your bacterial keratitis. Satellite lesion is seen in fungal keratitis, and dry-looking yellowish lesion with the feathery edges, you may see it in the fungal keratitis. Then you are having a corneal ulcer, ulcus serpens, strep pneumo, greenish exudate or contact lens, pseudomonas. Greenish exudate or contact lens, which is pseudomonas. Then you are having a signs of your keratoconus. Signs of keratoconus, early keratoconus, you may associate it with the oil drop sign, wax striae, and late is associated with the Fleischner's ring, Munson sign, Rizubi sign, and acute hydrops. All of them are named signs, which is very, 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 very important, people. All of them are named signs, which is pretty important. Then important fundoscopic findings, you may already know it. Anyway, we will do that. CRAO, cattle track appearance, blood and thunder, CRBO, CFAN retinopathy, sickle cell anemia, congenital syphilis, rubella, Leber's amaurosis, salt and pepper fundus, xerophthalmic fundus, Uemura fundus, angoid streak, Pierdo orange on retina is angoid streak, and Sturge-Weber syndrome, tomato ketchup fundus, and VKH syndrome, sunset glow fundus, toxoplasmosis, headlight and fog appearance. These are just kind of like a review thing. We have already discussed it inside. So we have talked about the keratitis, we have talked about the conjunctivitis, we have talked about the keratoconus, and we have talked about your retinal disorder, uveal disorder, conjunctival disorder, corneal disorders, and we have talked about the cataract, glaucoma, and we have talked about the basics of ophthalmology. So we have talked about the importance test and important named signs. We have talked about it already. So with this, we are completing our ophthalmology. Take a 10 minutes of break and come back by, like a 4:20. So we can proceed with the next subject. Okay. So with this, we are completing your ophthalmology. So speaking about this, covering this material will help you in at least 2 to 3 questions in ophthalmology. So make sure you know these things very well. Okay. Since it is a last minute revision, you should understand that this is totally a last minute revision where I don't want to, put a lot of points, and I don't want to make you learn new things here. Revision is important, people. So you might have already covered your FMG portion, and this is totally on like revision session where we can able to discuss only the important areas, and we cover only the important areas. You should understand that. Okay, take a break of 10 minutes and come back by 16:20 where we can able to discuss the next important subject, that is your pediatrics. Okay, if you could hear my voice and see the screen properly, type S on the chat box. If you could hear my voice and see the screen properly, type S on the chat box. We are proceeding with our pediatrics next session. We are proceeding with our pediatrics next session. So if you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box so that we can proceed with the pediatrics now. Speaking about the pediatrics, people. Okay, speaking about the pediatrics. Okay. Now, speaking about the pediatrics, the very, very important area is your growth and development. And apart from that, most of the area will be covered in the PSM as well as in the pathology, childhood pathology, you know. So that's why I don't want to mention much in the pediatrics. So reading about your, mastering your medicine and reading about your, pathology and the nutrition part in PSM and childhood traumas in the case of your surgery, that will help you in answer most of the questions in pediatrics. Okay. So what are the things we are going to study about here in the pediatrics is growth and development, and a few highlights we are going to see here. So first one, what are the terminologies we are having? What is so called as term? Term is a 37-week of completion of pregnancy is term pregnancy, and a preterm, we used to call it as a moderate to late, and a very preterm and extreme preterm. Extreme preterm is less than 28 weeks, while very preterm is 28 to 32, and moderate to late preterm is 32 to 37 weeks. 32 to 37, moderate to late preterm. Very preterm is 28 to 32 weeks, while extreme preterm is less than 28 weeks. Okay. And yearly term is 37 to 38. Full term is 39 to 40 weeks, and late term is 40 to 42 weeks. Late term is 40 to 42 weeks. When a full term is 39 to 40, and yearly term is 37 to 38. 37 to 38. Then you are having a post term. Post term is 42 or more than 42 weeks of pregnancy is a post term pregnancy. And apart from that, you are having a signs of maturity. Apart from that, you are having a signs of maturity on the baby. One is a neuromuscular maturity, posture, square window, arm recoil, popliteal angle, and scarf sign, and head to ear maturity are the one which is considered to be the components of your neuromuscular maturity. And physical maturity, you have to look for the skin, lanugo hair, and plantar surface, breast, ear, male genitalia or female genitalia. Okay, male genitalia or female genitalia in terms of your physical maturity. So minimum score should be 10 to 20 weeks, and maximum score should be 50 for 44 weeks. Minimum score is minus 10 for 20 weeks, and maximum score is 50 to 44. These are the signs. You may see it in the ultrasound during the stages, and you may think like these are the maturity signs and symbols. Okay, signs and components. Okay, apart from that ponderal index, we studied the ponderal index already in the PSM. So weight in gram by height in centimeter cube into 100 is a ponderal index. Ponderal index of more than 2, it is a asymmetrical intrauterine growth retardation. Ponderal index of more than less than 2, which is your equal or more than 2, which is your symmetrical IUGR. So more than 2, it is asymmetrical, equal to or less than 2 is your symmetrical. Okay, then you are having a neonatal hypothermia, axillary temperature of less than 36.5, cold stress 36 to 36.5, moderate 32 to 35.9, and severe hypothermia is less than 32 degree, and non-shivering thermogenesis, you may see it in this patient. Okay, so this is how we grade the hypothermia here. And apart from the types of feeding, so speaking about the types of feeding, if the baby is more than 1.25 kg and less than 28 weeks, you have to initiate the IV fluids, and 1.25 kg to 1.5 kg with the 28 to 31 OG feeds you have to initiate, and 1.5 to 2 kg with the 32 to 34 weeks, then feeding by spoon. Then more than 2 kg of more than 34 weeks, then you can do the breastfeeding. So IV fluids for severe malnutrition and breastfeeding for more than 2 kg with more than 34 weeks of pregnancy, you can do the breastfeeding. And apart from that, early sepsis, neonatal sepsis and late neonatal sepsis. So early neonatal sepsis is associated with the pneumonia, while the late one is associated with the meningitis. Late one is associated with the meningitis. What are the risk factors for this neonatal sepsis, people? What are the risk factors for this neonatal sepsis? For a low birth weight baby or premature baby have a higher risk. And apart from that, mom develops a 2 weeks of more than 2 weeks of fever, then there is a chance that the vertical transmission that can able to induce the neonatal sepsis. Apart from that, foul smelling or meconium stained liquor, one of the classical like risk factor for neonatal sepsis. And ROM of more than 24 hours, prolonged labor, perinatal asphyxia, Apgar score of less than 4. And apart from that, sterile, unclear, or more than 3 sterile vaginal examination can able to create your risk factor for your neonatal sepsis. So for acute or early neonatal sepsis, it is pneumonia. For late neonatal sepsis, mostly associated with the meningitis. Okay. Apart from that, most common cause of neonatal sepsis in India are Acinetobacter to over the Klebsiella. And what are the sepsis screen we are doing it, people? TLC of less than 5,000, total leukocytic count of less than 5,000, neutrophil count will be there, immature or total neutrophil will be more than 0.2, microscopic findings would be more than 15 mm and CRP of more than 1 mg per DL. So elevated CRP, TLC, neutrophil count and immature total neutrophil will be 0.2 in terms of your neonatal sepsis. So neonatal sepsis, most common cause for a early, it is a pneumonia. For a late, it is a meningitis. Most common organism causing a neonatal sepsis in India is mostly associated with the Acinetobacter over the Klebsiella. Acinetobacter over the Klebsiella. So apart from that, we are going to talk about the apnea of your prematurity. We are going to talk about the apnea of your prematurity. No breathing for more than 20 seconds. No breathing for more than 20 seconds or less than 20 seconds with the decrease in heart rate and the cyanosis, then that is a apnea of prematurity. So there could be a two causes, either a central cause or there may be an obstructive cause. Central cause is respiratory center depression or obstruction is due to the neck flexion. Obstruction is due to the neck flexion, while the most common causes are both central and obstruction. Drug of choice is IV caffeine. Okay, drug of choice is IV caffeine. And apart from that, congenital diaphragmatic hernia. Speaking about the congenital diaphragmatic hernia, the predictors of prognosis was associated with the major anomaly and symptomatic with the 6 hours of life, pulmonary hypoplasia, herniation to the contralateral side, echo, and deletion and detection in the first trimester. Okay, detection in the first trimester. So outcome index of more than 40 and response to inotropes is not there. Outcome index of more than 40 and lack of response to inotropes, then there is an increase in mortality. Go for the echo and echo fails, then it can able to say that the baby is dead. The baby is dead. How do you calculate the outcome index? MP into FiO2 into 100 divided by postductal PaO2 is your outcome index. And apart from that, HIE, hypoxic ischemic encephalopathy. So where do you see the therapeutic hypothermia? Therapeutic hypothermia 33 to 34.5 degrees centigrade with the 6 hours of more than 36 hours. Drug of choice for neonatal seizure is phenobarbital. And staging for a hypoxic ischemic encephalopathy is Sarnath staging. So where you may see the seizure in stage 2, mydriatic pupil in stage 1, myotic pupil in stage 2, and burst suppression pattern of EEG in stage 3. Burst suppression pattern of EEG in stage 3. Okay, apart from that, football sign on X-ray indicates pneumoperitoneum. Pneumostasis intestinalis, air under the bowel wall, you may see. Air under the bowel wall, you may see. These are the important one. You may see it in the case of your emergencies, pediatric emergencies, people. Apnea of prematurity, congenital diaphragmatic hernia, HIE, and neonatal sepsis are all the pediatric emergencies. So apart from that, NNEC, distal ileum and proximal colon will be involved. neonatal enterocolitis, which is also a GA emergency, where the triad of symptoms of intestinal ischemia, external nutrition, and bacterial translocation you may see. Okay, bacterial translocation, interstitial ischemia, and external enteral nutrition you may see. And NNEC is a neonatal emergency, GA emergency. And you may see the metabolic triad in this NNEC patient: metabolic acidosis with the hyponatremia and refractory thrombocytopenia. Refractory thrombocytopenia, hyponatremia, and metabolic acidosis is a classical triad of symptoms. And apart from the risk factors are PT or formula feeds, you may see it in this NNEC. And histopathological findings shows a coagulation necrosis. Coagulation necrosis. For NNEC, what is the staging we are using? Modified Bell staging. While star knot staging is used in, SAR knot staging is used in neonatal HIE, while modified Bell staging is used in NNEC. Okay, occult blood in stool 1A, gross blood in stool 1B, blood or no bowel sound plus abdominal tenderness or nematosis intestinalis in X-ray 2A, cellulitis, mass, portal vein gas on X-ray 2B. Okay. Apart from that, marked tenderness plus distended abdomen, ascites 3A, ascites plus pneumoperitoneum, that is 3B. Ascites plus pneumoperitoneum, that is 3B. Okay, these are the modified Bell staging for NNEC. So mild blood 1A, gross blood 1B, blood with no bowel sound with abdominal tenderness with the nematosis intestinalis 2A, cellulitis, portal venous gas 2B, marked tenderness, distended abdomen, ascites, you are having it in the 3A, and ascites plus pneumoperitoneum, which is 3B, which is 3B. Apart from that, neonatal jaundice, you may have a phototherapy. So speaking about the phototherapy, most important part is your structural isomerization is a most important part in your phototherapy. Contraindicated in porphyria, light wavelength of 420 to 470 nm. Mix should be black and white light should be, blue and white light should be mixed, and the distance should be 45 centimeter from the light source. Intestine phototherapy should be 15 to 20 centimeter. Bilirubin decline should be 1 to 2 mg per dl for 4 to 6 hours. So this is the targeted guidelines for your phototherapy. So most important part in the phototherapy was structural isomerization, contraindicated in porphyria patient because the light can able to create a consequences in the porphyria patient. Yes or no? Apart from that, light wavelength 420 to 470 nanometer of light should be there, and that should be a mixture of your blue and white light, people. That should also be a mixture of blue and white light. Distance should be 45 centimeters from the light source. Intestine phototherapy should be 15 to 20 centimeters from the light source. And bilirubin decline for neonatal jaundice in this phototherapy, how much should be there? 1 to 2 mg per deciliter for 4 to 6 hours of phototherapy session. For every 4 to 6 hours of phototherapy, there should be a decline in 1 to 2 mg per deciliter of your bilirubin. Okay, this is all about the phototherapy. Next is your vaccines and their complication. So first one, measles can produce toxic shock syndrome. Light sensitive vaccines are BCG, measles, rotavirus, HPV, and Tdap, while subcutaneous route are measles, Japanese encephalitis, and chickenpox, poliovirus, type 3 VAPP, and type 2 VDPV. Okay, type 2 VDPV. We talked about the, vaccines in the PSM. If you want PSM part 1, you may see this vaccine part. Each and every, and there's training and their where to location, what are the dosage, everything was mentioned there. Absolute contraindication, any progressive neurological disease, vaccination is contraindicated. In DPT, anaphylaxis, encephalopathy of less than 7 days. Anaphylaxis and encephalopathy of less than 7 days, which is contraindicated. Okay. Apart from that, common diarrheal diseases, one is your rotavirus is the most common cause of acute gastroenteritis in pediatric, and rotavirus vaccine should be administered by 6 weeks, and Rotavac 116E in India, Rotarex RV1 and RV5 on 10 or 14 weeks or 6, 10 or 14 weeks you have to give. Contraindicated in intussusception patient. Rotavirus is contraindicated in intussusception. Maximum age was 14 weeks and 6 days. 14 weeks and 6 days was the maximum age for rotavirus. Maximum age for rotavirus. Then you have a kwashiorkor, nutritional disease, growth retardation, apathy, and edema is the triad of symptoms in kwashiorkor. Rickets, we talked about the rickets already back in the biochemistry. Anyway, we talk about the types of rickets. Type 1, 1-alpha hydroxylase deficiency. Type 2, end organ receptor resistant. And type 3, PEX gene defect. For type 3 is PEX gene defect. And apart from that, type 2, there is no other treatment is required. Vitamin D levels will be normal. Type 1, you have to give a calcitriol directly, 1,25 dihydroxycholecalciferol. While X-linked hypophosphatemic rickets, you have to give vitamin D along with the oral fluids. Vitamin D along with the oral fluids you have to give for the X-linked hypophosphatemic rickets. So type 1, which is a 1-alpha hydroxylase renal defect. Type 2, which is a end organ receptor defect. And X-linked hypophosphatemic one, which is a PEX gene defect. Very, 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 very important one is the mechanism. They may give you as a clue. Okay, you have to remember that. And the earliest sign of the rickets is features of rickets we have studied yesterday in the orthopedics. Like what are they? Craniosynostosis, craniotuberous, and Harrison groove, rachitic rosary, and you have this wind-swept deformity, kyphosis, scoliosis, lordosis, and swelling of your hands and wrist. Everything we have studied in the case of your rickets yesterday in the orthopedics. So earliest sign is the soft skull and Harrison groove, which we knew already. Okay, so here we talked about the types of rickets, which is very, 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 very important. Okay, then pneumonia. Speaking about the pneumonia, Staph aureus is the most common cause. And apart from that, you may see the mycoplasma, which is responsible to macrolides. And mycoplasma can produce arthralgia and anemia. Drug of choice is ampicillin for listeria, which is 50 mg per kg per day. Okay, RR of 0 to 2 is 60, and 2 to 4 is 50, and 4 to 5 is 40. Okay, and apart from that pneumonia, there are 3 types of symptoms. You may see it in the pneumonia: no pneumonia, or tachypnea, or chest compression. Tachypnea indicates a pneumonia, while chest compressions indicate severe pneumonia. Chest compression indicates very severe pneumonia. So remember, if the child is not responding after the 4 to 5 hours of treatment, then do the repeat X-ray and do the VADTS. And apart from that, you can do the pulmonary sequestration. Pulmonary sequestration also for this severe pneumonia. Then you are having a congenital cystic adenoid malformation, where you may see there is a type 1, type 2, and type 3. Congenital cystic adenoid malformation, where you see type 1, type 2, type 3. Type 1 is a good prognosis, type 2 and 3 are bad prognosis. And CCAM, you see the injury with the 35th week of gestation. And dysplastic and mediastinal shift will also be seen. And like a clinical features of your RD will be associated with the congenital cystic adenoid malformation. And apart from that, you may see the bilateral pneumothorax associated with the Marfan syndrome, cystic fibrosis, alpha-1 antitrypsin deficiency, and Ehlers-Danlos syndrome. Ehlers-Danlos syndrome. Then bilateral conal atresia associated with the Charge syndrome, CHD7 defect. And apart from that, CLTB, T1 is mild, you don't need to do anything. T2 is moderate, dexamethasone, while T3 is severe, where you may see the epinephrine or Rasmerize you can able to give into this patient. Then pediatric asthma. Speaking about the diagnosis is spirometry, and you see the uncontrolled asthma will be in the red zone, where you may see more than 50% on the PEF peak flow meter. You may see more or less than 50%. Then congenital toxoplasmosis, cerebral calcification, hydrocephalus, and chorioretinitis. Cerebral calcification, hydrocephalus, and chorioretinitis. Treatment of choices pyrimethamine and sulfur dioxazine. And apart from that, Sturge-Weber syndrome, which is a port wine stain, tubular sclerosis, you may see the epiloia. Epiloia is epilepsy with the low IQ and adenoma fibroma. And in the case of your tuberous sclerosis, you may see the Shagry's patch and retinohematoma, rhabdomyoma, lymphangiomatosis, and candle rippling appearance on MRI. Candle rippling appearance on MRI, and you may see rhabdomyoma, retinohematoma, and Chagrie's patch on tuberous sclerosis, where you may see the epiloia features, epilepsy, low IQ, and you may see that there is a adenoma fibroma. Then you are having a neurofibromatosis, Cafe-Ollet spot, chromosome number 17 and 22q defect, Lischke nodules on eyes you may see, NF2 vestibular schwannoma you may see. Vestibular schwannoma you may see associated with the neurofibromatosis type 2. Then you are having a Von Hippel-Lindau disease, cerebellar hemangioblastoma, retinal angioma, and cystic lesions. You may see it with the Von Hippel-Lindau disease. Then apart from that, you have a ATM gene defect, DNA ataxia telangiectasia, ATM gene defect, IgA, G, and E can cause a recurrent sinopulmonary infection. Then lechencephaly, no sulci or gyri, schizencephaly, abnormal connection. Microcephaly, and an average weight of the skull with less than with the -3 standard deviation. If it is more than +2 standard deviation, that is a hydrocephaly. Okay, where you may see McEwen sign if the cranial suture is closed, and normal size of anterior fontanelle would be 2 into 2 centimeter. Quite a straightforward basic neuro question, people. Then you are having this West syndrome, hypsarthria, infantile spasm, and developmental regression. Developmental regression. So as we said, you may see that the juvenile infantile spasm, the drug of choice, we studied that in the pharmacology. As I said, any type of epilepsy, what is the drug of choice? For the any type of epilepsy, what is the drug of choice you have to give? What is the drug of choice for any type of generalized epilepsy? Sodium valproate, yes or no? Apart from sodium valproate, it is not indicated in status epilepticus and juvenile infantile spasm or West syndrome. I said, for a juvenile infantile spasm or West syndrome, what is the drug of choice? ACTH is a drug of choice. If the juvenile infantile spasm is associated with the West syndrome, if the juvenile infantile spasm is associated with the West syndrome, then vigabatrin is a drug of choice. Then vigabatrin is a drug of choice. Okay, ACTH and vigabatrin will be there as a drug of choice. Okay, and apart from that, Rolandic epilepsy, which is a benign one, which is walking at night with the seizure, is a Rolandic epilepsy, where EEG show centrotemporal spike wave appearance, while drug of choice is carbamazepine. While the drug of choice is carbamazepine in terms of your Rolandic epilepsy, which is a pediatric type, walking at night with the seizure, and EEG showed centrotemporal spike wave. Centrotemporal spike wave. Then Lennox-Gastaut syndrome, where you may see the multiple seizure, EEG shows 1 to 2 hits of spike and wave appearance, and you may also see the developmental delay. You may also see the developmental delay. Apart from that, Landau-Kleffner, which is associated with the autism, boys of more than 5.5 years, hearing is normal, loss of language skill will be there, and the treatment of choice is valproic acid. Valproic acid. Apart from that, spastic diplegia, where you may see the periventricular leukoplakia associated with the prematurity and with the arginase deficiency. With the arginase deficiency, you may see the spastic diplegia. Then apart from that, in the CNS, you are having a CNS meningitis, neonatal meningitis, and encephalitis. Meningitis is associated with the bacteria, and you may see that the group B streptococci after 1 year, then strep pneumo. So neonatal, it is a group B streptococci. After 1 year, it is strep pneumo. And for encephalitis, HSV2, meningitis and encephalitis progression, then mostly viral, followed by enterococcal. Then mostly viral, followed by enterococcal. Then poor prognosis of meningitis is seen in age less than 6 months, seizures of more than 4 days, high concentration of bacterial load in CSF, increased mortality with the pneumococcal. Increased mortality with the pneumococcal. Then you are having a SSPE, which is a late complication of measles, and EEG shows rhythmic pattern, 3-in-1 pattern. And apart from that, you may see there is a coma, spasticity, ocular abnormality, and photosensitivity. Coma, spasticity, ocular abnormality, and photosensitivity or the progression of your SSPE. So technically speaking, coma is the last stage. Coma is a last stage. So if it starts from the photosensitivity to ocular abnormality to spasticity and then to the coma. While physical changes, what we observe here was a personality change followed by seizure, followed by myoclonus and ataxia. Okay, followed by myoclonus and ataxia. But main things are your photosensitivity, ocular abnormalities, spasticity, and coma. Spasticity and coma are the four important signs of your, SSPE. Okay, and apart from that, gray matter and white matter. So gray matter, cortical and basal ganglia. Basal ganglia gray matter disorders are associated with the Wilson disease, Huntington chorea, and Haller-Walden-Spot syndrome. While in the case of your cortical storage, mainly associated with the organomegaly like a Gaucher, Niemann-Pick's, and mucopolysaccharidosis. And without organomegaly should be Tay-Sachs, neuronal, and ceroid lipofuscions you may see. Apart from that, cerebellum, Friedreich's ataxia and telangiectasia will be there. And white matter disorders, hypermyelination, abnormal demyelinating disorder, Schiller's disease, acute disseminated encephalomyelitis. Schiller's disease, multiple sclerosis, and acute disseminated encephalomyelitis are the white matter disorder. Okay, so these are the important ones you have to know. Apart from that, pediatric GERD disorder, pathological GERD is associated with the respiratory syndrome or associated with the Sandifer syndrome. Sandifer syndrome. And we are having an Allogrove syndrome where you see the achalasia, adrenal insufficiency, and alacremia. Then causative organism, you may see what type of necrotic tissues, coagulation in acidic and liquefaction in alkali. Coagulation in acidic and liquefaction in alkali. So apart from that, you may have this. The nutrition and development. So speaking about the developmental milestone, people, speaking about the developmental milestone, we are having important things in the case of your developmental milestone. Let me load it. Let me load the developmental milestone. It's not coming up. Yeah. So this page is again one of the page where you have to know before your, your examination, like 1 hour before the examination, you have to know this. So speaking about the developmental milestone, motor skills, neck holding for 3 meter, rolls over by 5 month, and sits with support by 6th month, without support by 8th month. So what are the motor skills? Neck holding for 3rd month, rolls over by 5th month, sits with support by 6th month, and without support by 8th month. And crawls by 9th month, pulls from supine to sitting by 10th month, creeps well by 12th month, walks without a support by 15th month, runs by 1.5 year, climbing stairs with help by 1.5 and without help by 2 years, and a tricycle by 3 years, and catches ball reliably by 4 years, and skipping by 5 years. So what are the motor skills? Neck holding 3 months, rolls over 5 months, sits with the support 6 months, without support 8 months, and stand without support by 12 months, walks without support by 15 months, run by 1.5 year, climbing stair without support by 2 years, tricycle by 3 years, and catches balls by 4 years, skipping by 5 years. Catches balls by 4 years and skipping by 5 years. So these are the motor skill people. So rolls over 5th month, sits without support, 8th month, crawls by 9th month, creeps well or stand without support by 12, walks without support by 15, climbs stairs without support by 2 years, runs by 1.5 year, tricycle by 3 years, skipping by 5 years. So these are the important motor skills. And apart from that, important fine motor skills, follows the moving object by 3rd month, and bidextrous reach by 4th month, pincer grasp by 9th month, turn 2 to 3 pages by 12th month, feeds himself with the spoon by 15th month, makes a tower of 2 cube 15, 3 cube 18, 6 cube 2 year, and 9 cube 3 year, build a bridge by 4th year, and builds a gate by 5th year. So make tower 2 by the 15, 3 by 18, 6 by 22 years, and 9 by 3 year, and builds a bridge by 4th year, and builds a gate by 5th year. Apart from that, the patient, a mnemonic I used to remember with the Lockstead. So straight line 1.5 year, horizontal line 2 year, circle 3 year, X and a square 4 year, triangle 5 year, diamond 7 year, triangle 5 year, and diamond 7 year. That's the mnemonic I used to remember. So straight line 1.5 year, horizontal line 2 years, and circle 3 years, X and a square, which is 4 years, triangle 5 years, diamond 7 years. Diamond by 7 years, he will draw the diamond. Then, speaking about that, so we have talked about the motor skill and the fine motor skill. We have talked about the motor skill and the fine motor skill. Then language skill, response to the sound of bell by 1 month, cooing by the third month, monosyllabic word by 6 months, bisyllabic words by ninth month, says a meaningful word, 2 words by 12th month, 3 to 5 words by 15th month, and 10 words by 18th month. Okay, 3 to 5 words by 15th month and 10 words by 18 months. And says sentence, 2 word sentence by 2 year, 3 word sentence by 3 years. And knows colors and tells story by 4 year, asking meaning of words by 5 year, asking meaning of words by 5 years. Okay, so apart from that, social skills. Speaking about the social skills, social smiles begin by 2 months, and recognizes mother by 3 months, recognizes strangers by sixth month, waves the bye-bye by ninth month, object consistency is seen in the ninth month, comes when called and plays the simple game by 12th month, temper tantrum by 15th month, and you have this copies the parent action or domestic mimicry by 18th month. Best time to start the toilet training is the 18th month, and two-step command following is 2nd year, button clothing fully by 4th year, dresses without a supervision by 5th year, dresses without a supervision by 5th year. So waves bye-bye by ninth month, and comes when called and plays a simple game by 12th month, temper tantrum by 15, and copies the parents or domestic mimicry by 18. Best time to start the toilet training is by 18. Two-step command following by 2 years, button clothing by 4, dresses without supervision by 5, dresses without supervision by 5. So these are the important social skills, and these are the important language skills. Okay, apart from that, we are having a red flag signs. So no visual fixation by 2 months, no vocalization by 6 months, not sitting without support by 9 or 10th month, not standing alone by 16 months, not walking alone or not no single work by 18 months, lack of imaginative play by 3 years, lack of comprehension or single words or phrases at any age, or the one where you may see it as a red flag sign, people. That's the time the patient attender have to goes to the pediatrician. Okay, no visual fixation by second month, vocalization by 6 months, not sitting with support by 9 to 10, not standing alone by 16, not walking alone by 18, lack of imaginative play by 3, lack of comprehension or phrases at any age is by the at any age or the red flag signs that you have to remember. So this 2 pages are again one of the pages where you have to take it to your home, and you have to print it, and you have to read 1 hour prior to your examination so that you can answer it right. There are few things you have to read 1 hour prior to the examination, and you have to, this page is one of the page where you have to turn around and you have to learn and you have to answer it in a very fine way, people. Okay, so developmental developmental milestone and the red flag signs are one of the high yield region in the pediatrics, while other portions like like the neonatal jaundice and all, we covered that in the pathology and medicine. So that's why I'm skipping it over here. So anyways, so we finished the pediatrics, we move on to the psychiatry now. We finished the pediatrics and we move on to the psychiatry now. So speaking about the psychiatry, there are certain important definitions you have to know. One is your ecstasy, very severe elevation of mood is so called as ecstasy. Deja vu, a sense of familiarity with unfamiliar situations, while Jamayu, exactly opposite, sense of unfamiliarity with the familiar situation. Apart from that, hallucination, a perception that occurs in the absence of stimulus is a hallucination, and illusion is a misinterpretation of the stimulus from the external world. Misinterpretation of the stimulus from the external world is a illusion, while hallucination is a perception without a stimulus. For example, a person is talking to you, that is a hallucination, and you think like there is a object which is standing on there. Technically, that might be any object, but you imagine that that is the person and that is talking to you. That is illusion. Illusion means misinterpretation of the stimulus from the external world, while hallucination is absence of the stimulus. Perception occurs in the absence of the stimulus is hallucination. Misinterpretation of the stimulus is illusion. Then you have a mood, that is a pervasive or sustained emotion that colors the person's perception to the world as a mood. And you have this phobia, irrational fear of an object or situation is so called as phobia. And apart from that, neologism, the neologism means the formation of a new words, formation of a new words and the simple words that they can form on their own. New words are simple words that they can form on their own. Apart from that, psychosis, which lacks insight, while neurosis, which has insight. Psychosis is the one which do not contains the insight, while neurosis is the one which contains an insight. Okay, and apart from that, what are the few important tests we are having in this? We are having in the psychiatry: ADHD, corner rating scale, intelligence test, Binet command test, or Restless scale, or Ravenny progressive matrices, insomnia, Epworth scale, postpartum depression, Edinburgh scale, and organic brain syndrome, Bender Gestalt test. Bender Gestalt test. Apart from that, important phobias are here: fear of height, acrophobia; fear of darkness, nyctophobia; fear of pain, algophobia; fear of medical procedures, trypanophobia; fear of sexual abuse, agoraphobia; and fear of spider, arachnophobia; fear of blushing, pyrophobia; and fear of closed spaces, claustrophobia. Fear of closed spaces, claustrophobia. Apart from that, IQ, mental age by chronological age into 100, 0 to 25, it is idiot, and 26 to 49, imbecile, 50 to 69 is moron, and 70 to 75, 79 is borderline, 80 to 89 is low normal, 90 to 110 is normal, 110 to 119 is superior, 120 to 139 is very superior, and more than 140 is genius. More than 140 is genius. Okay, so IQ, we discussed that already in the PSM. Apart from that, important phobias we have discussed. Next is the impulsive disorders. Speaking about the impulsive disorders, we are having a pyromania, fire setting without a motive; kleptomania, theft without a motive; onychophagia, compulsive nail biting; orgasm, compulsive masturbation; and oniomania, compulsive buying. Oniomania is a compulsive buying. Onychophagia is compulsive nail biting. Kleptomania, theft without a motive. Pyromania, fire setting without a motive. Okay, fire setting without a motive. Then you are having a personality disorder. What type of personality disorder? And schizoid one is the people, a condition in which people avoid the social activity and interacting with others is a schizoid. And mental disorder characterized by severe social anxiety, paranoia, and often unconventional belief is your schizotypal disorder. And apart from that, paranoid, heavily infused by the anxiety or fear, often to the point of delusion and long-standing suspiciousness and general mistrust of others. General mistrust of others is the paranoid one. And antisocial, gross attitude for irresponsibility and disregard for social norms, rule, and obligation is your antisocial. Histrionic, pattern of excessive attention seeking emotions, excessive attention seeking emotion, including inappropriately seductive behavior and excessive need for approval. And excessive need for approval. Then narcissistic, where the patient overthinks about themselves, where the inflated sense of their own importance will be there. And borderline, unstable moods, behavior, and relationships. Unstable moods, behavior, and relationships are the borderline personality disorders. So these are the personality disorders. So we are having a what type of disorders? Schizoid, schizotypal, paranoid, antisocial, histrionic, narcissistic, and borderline. Borderline, you can easily say the patients with the cut, so that the patient is having unstable mood, suicidal, threatening, and they have a failed relationship. So any case scenario, 28-year-old woman has been brought to the ICU by after cutting her hands by her partner. She says that she is having a, when the partner was trying to move on, she do not want her partner to move on, and they had an argument, and she had cut her hand. That's the classical scenario they may give you for the borderline personality disorder. And narcissistic personality disorder, the patient who totally thinks about himself, and the patient who totally trains himself to be the better person, and they give an importance to the oneself, not to the others, is a narcissistic personality disorder. Then you have a histrionic one, where attention seeking, inappropriate seductive behavior, excessive need for approval is histrionic. Antisocial, irresponsibility, disregard of social norms, rule, and obligations is antisocial. Paranoid, excessive fear, anxiety, delusion, long-standing suspiciousness, and you may see there is a, these type of people will never trust anybody. And schizotypal, mental disorder, which is characterized by severe social anxiety, paranoia, and often unconventional belief. Okay, schizoid one, where the people avoid social activity and interacting with the others, is a schizoid one. Okay, apart from that, you are having a, you are having this developmental milestone. So oral 0 to 1, 1.5 age, anal 1 to 1.5 to 3 age, and phallic 3 to 5, latent 5 to 11, and genital more than 11. Okay, and apart from that, EEG waves. So alpha bridges the gap between your conscious thinking and subconscious thinking. Beta, observed when we are awake and logical thinking. Gamma, hypercognitive functions like learning, memory, and information processing. And delta, found in children and infant. Theta, involved in daydreaming and sleeping. So now here, people, they may ask you the question, what are the EEG changes during the sleep? EEG changes during the sleep. I used to follow the first aid for USMLE step 1, which is having a wonderful mnemonic for this. Okay. Bats drink blood was the mnemonic. Bats drink blood was the mnemonic. So B stands for beta, beta wave, normal, eye open, eye open. A stands for alpha wave, where normal, eye closed. T stands for theta wave, where stage 1 NREM. S stands for sleep spindles, sleep spindles, stage 2 NREM. And D stands for delta, where stage 3 and 4 NREM. And B stands for again beta REM. B stands for again beta REM, which is one of the quiet, easy thing mnemonic to remember. Bats drink blood. These are the EEG changes with the EEG changes during the sleep. They had asked several times in FMGE, so write it next to your notes, like a bats drink blood. B stands for beta wave, where normal eye open. A stands for alpha wave, normal eye closed. T stands for theta wave, stage 1 NREM. S stands for sleep spindles, stage 2 NREM. And D stands for delta wave, stage 3 and 4 NREM. And B stands for beta wave, REM. B stands for beta wave, which is the REM sleep. Okay, so these are the EEG waves. Then apart from that, you're having a schizophrenia. Speaking about the schizophrenia, chronic debilitating disorder where the patients has a loss of, loss in reality will be there. So insight is totally absent. Insight is totally absent. 4 A's will be there: ambivalence, autism, loss of association, and affect disturbance. Okay, loss of association and affect disturbance are the 4 A's of your schizophrenia. Positive symptoms: delusion and hallucination. While negative symptoms: emotivation, allogia, anhedonia, ebulia, and asociality. Okay, amotivation, elogia, anhedonia, ebulia, and asociality. Apart from that, Schneider's first rank symptoms: hallucination, delusional perception, thought disorder, somatic passivity, and impulsive acts. Hallucination, delusional perception, thought disorder, somatic passivity, and impulse act. Second rank symptoms: other perceptions, sudden delusion, perplexity, depression, and euphoria. Perplexity, depression, and euphoria. Best prognosis is catatonic, good prognosis is paranoid, and bad prognosis is hypophrenic. Worst prognosis is simple schizophrenia. Worst prognosis is simple schizophrenia. Then delirium, organic brain syndrome, delirium, organic brain syndrome, or acute confusional stage. Clouding of consciousness will be there in delirium. Sundowning phenomenon will be there, and the psychomotor disturbance will be there. Psychomotor disturbance will be there. And delusion, disorder of thought, false belief with the extraordinary convincity is a delusion. Most common type is a delusion of persecution. Delusion of persecution. And dementia, memory impairment with two of the four conditions. Memory dementia is memory impairment with two of the four conditions, which is your agnosia, apraxia, aphasia, or impaired executive function, or personality disintegration, or catastrophic reaction. Any of these two will be there, along with the memory impairment is so called as dementia. And what is the dementia we can use? MMSC scoring is the dementia we can use. Most commonly associated with Alzheimer's. Most commonly associated with Alzheimer's. And apart from that, Lewy body dementia is seen in Parkinson's. So memory impairment along with the two of the following: agnosia, apraxia, aphasia, impaired executive function, and personality disintegration and catastrophic reaction. Personality disintegration and catastrophic reaction is so called as dementia, most commonly associated with the Alzheimer's, and Lewy body dementia is seen in Parkinson's. EEG abnormalities are seen in Creutzfeldt-Jacobs disease. And apart from that, and pseudo dementia is associated with the depression. Pseudo dementia is associated with the depression. Okay. Then you are having a cognitive function, MMSC score of cognitive function, and delusion. Delusion of body being ugly is a delusional dysmorphia, and the delusion of doubles or a secret lover is Capgras syndrome. Delusion of foreign body infestation is delusional halitosis, and delusion of grandiosity or inflated self-image is mania, and delusion of guilt and poverty is depression, and delusion of infidelity or reference or persecution is paranoid schizophrenia. Delusion of love or erotism is seen in Clermont syndrome or erotomania. Worm infestation, delusional parasitosis, and a fragmentary delusion is delirium with the hypophrenic schizophrenia. And jealousy involving a spouse is a Othello syndrome or conjugal paranoia. And nihilistic delusion is seen in depression. Nihilistic delusion is seen in depression. And apart from that, you may see the Beck triads in the depression, where you see the hopelessness, helplessness, and worthlessness. It's a Beck's triad of depression. And atypical depression is the most common subtype. Atypical depression is the most common subtype of your depression. Apart from that, substance abuse, the common names are pretty important. Speed is amphetamine, angel dust is pencyclidine, smack or brown sugar is heroin, gold rush or popper is amyl nitrate, idiotic pills are barbiturate, white heroin is China white. White heroin is China white. So China white is white heroin, speed is amphetamine, angel dust is pencyclidine, brown sugar is heroin, gold rush or poppers is amyl nitrate, and idiot pills are barbiturate. Idiot pills are barbiturates. And apart from that, you are having the sleep. We have done the sleep part already. Next is the eating disorder, anorexia nervosa and bulimia nervosa. Eating more, losing weight is bulimia nervosa. Don't eat in order to lose weight is anorexia nervosa. So don't eat in order to lose weight is anorexia nervosa, while bulimia nervosa is binge eating will be there. The patients eat more and tries to vomit so that they believe like it won't go to their stomach. and they won't gain weight. That is a bulimia nervosa. So you may see that there is a enamel erosion, pancreatic hypertrophy, dental caries, or anything which is related to the self-induced vomiting complications are seen in the bulimia nervosa, while anemia, thrombocytopenia, nutritional deficiency is associated with the anorexia nervosa. Who are anorexia? If we eat more, we may lose weight, we may get fat. That is the firm belief, so that the patient will not eat in order to maintain the weight as anorexia. And the patient eats more and tries to vomit so that the food may go out and they will not gain weight. That is so called as bulimia nervosa. Binge eating is seen in bulimia nervosa. Self-induced vomiting is seen in bulimia nervosa. Anemia is seen in anorexia nervosa, and osteopenia is seen in the anorexia nervosa. And all the malnutrition features is also seen in anorexia nervosa. Apart from that, you may see that there is a, like pathways of antipsychotics: mesocortical, negative symptoms; mesolimbic, positive symptoms; nigrostriatal, extrapyramidal; and tuberoinfundibular, hyperprolactinemia. Then apart from that, you have a diagnostic duration of your psychiatric illness: hypomania 4 days, mania 1 week, depression 2 weeks, OCD 2 weeks, acute psychosis less than 1 month, PTSD more than 1 month, delusional psychosis less than 3 months, schizophreniform disorder less than 6 months, schizophrenia more than 6 months, generalized anxiety 6 months, chronic grief more than 6 months, dysthymia or cyclothymia, which is more than 2 months. Okay, chronic grief, schizophrenia, dysthymia was asked several times in FMGE as a duration of diagnosis. Duration of diagnosis. So very important. Okay. Apart from that, defense system, most mature defense mechanism is your humor. Most mature defense mechanism is defense mechanism is humor. Defense mechanism is humor. Humor. Apart from that, repression is seen in psychogenic amnesia, denial is seen in psychosis, projection is seen in persecutory delusion or hallucination, distortion is associated with the megalomaniac belief, regression is associated with the neurosis and psychosis, displacement is associated with the phobia, inhibition is associated with the OCD, and undoing is associated with the OCD and the compulsive ritual. And apart from that, reaction formation is associated with the OCD trait, and identification is associated with the pathological grief conversion disorder. Identification is associated with the pathological grief conversion disorder. So this is all about your psychiatry, people. This is all about your psychiatry that you have to know. Quite an important one, very easy one. So types of maniac and diagnosis duration and important definitions and the types of phobia are the things that they may ask you in the FMGU question as a psychiatry, or type of personality disorder they may ask you. So be prepared and all the very best. So with this, we are completing your psychiatry, people. With this, we are completing your psychiatry. So last one is radiology. So images are the pretty important one in the case of your radiology. Since we have covered most of the images, here are some of the radiological signs and things. You may see it here. Let me put you over here. Radiology. So speaking about the radiology. So first one, X-ray PA chest. If they are given you a typical chest and they ask you what is the things. So first one is your clavicle, and next in the clavicle you see that there is a mark above the clavicle. You see the clavicle here. Above the mark, you may see there is a small one, which is your apex of your lung, and this bone is a clavicle is a bone, and above the clavicular bone you see the apex of your lung. And apart from that, you may see that there is a small spine of your scapula. You may see there is a spine of your scapula here. You may see the spine of a scapula here. And apart from the spine of the scapula, you may also see the tracheal rings. And apart from that, you may see the aortic arch here. and eighth posterior rib, and apart from that cardiophrenic angle, this is a cardiophrenic angle, this is a costophrenic angle, these are the ribs, and apart from that liver, which is going on from here, apart from that liver, diaphragm and air in the fundus stomach, and apart from that left hemidiaphragm. So what are the important things you need to know in the case of your X-ray chest test? You have to look for the bones. So all the clavicle is there. Yes, clavicle is there. Ribs are there. Yes, all of the bones are visible. At least, Alexa, stop. Okay, so these are the important bones. Then you see the trachea. Then you see the aortic arch. Then you may see that there is a diaphragm. Diaphragm, two angles you have to see. One is a cardiophrenic angle, another one is a costophrenic angle, followed by liver, stomach, liver and stomach. Apart from that, you see here the upright abdomen. Here is the liver, and here is a hemidiaphragm, and here is a 12th rib, you may see, and here is a air or fluid levels, and this is a spinous process of your L4 and top of your iliac crest. So these are the important signs in the radiology. One is your bamboo sign, one is your bamboo spine, which you may see it in the ankylosing spondylosis, pencil and cup deformity, psoriasis, gout. Here is the picture of your gout, and then osteochondroma, you may see here, enchondroma, you may see it here, and apart from that aneurysmal bone cyst, you may see it here, osteosarcoma and Ewing sarcoma, where you may see the onion peel reaction, and light lesions, and you may see the hair on end appearance, on the skull, thalassemia and sickle cell anemia, and punched out lesion. Here you may see the punched out lesion, which is seen in multiple myeloma, cotton wool skull, seen in Paget's disease, and blades of grass, which you may see it in the Paget's disease, codfish vertebra. Here you may see the codfish vertebra or fish mouth vertebra, and apart from that, you may see the pneumothorax. So speaking about the pneumothorax, the air in the thorax region. So air in the thorax region, which can able to affect your, like a diaphragm, and you may see that there is a deep sulcus sign. You may see there is a deep sulcus sign, and you may see the anterior costophrenic angle will be blunted. Along with that, air you may see it in the diaphragm. Okay, air we may see it in the dome of the diaphragm, that indicates the pneumothorax. Apart from that Epstein anomaly, you may see the box-shaped heart, and you may see that there is a pneumopericardium, where you may see the air in the pericardial cavity, and lobar pneumonia picture. And apart from that, silicosis, where you see the axial calcification or snowstorm appearance, ground glass opacities in ARDS. And apart from that, you may see there is a tetralogy of Fallot, where you may see the boot-shaped heart, cannon ball metastasis in the RCC and the choriocarcinoma, transposition of great vessels, where you may see the egg-on string appearance, and you may see the coaction of aorta, figure of 3 appearance. You may see it in the coaction of aorta. And apart from that, you may see there is a tuberculosis, Gons focus and Gons complex. You may see here in the TB. And the miliary TB, you may see the snowstorm appearance. Meningioma, typical one. And the brain abscess, which will be dark here in the CT. And apart from that, you may see the moth-eaten skull, which is due to the metastasis. Corkscrew esophagus, where you may see it in the desk. Bird beak appearance, achalasia cardia. Double bubble sign, duodenal atresia. CHPS spring sign. Midgut volvulus. And apart from the triple bubble sign, you may see it in the jejunal atresia. And apart from that, you may see that there is a red raindrop skull, which is your multiple myeloma or punched out lesion, which you may see here. And apart from that, ivory vertebra, Paget's disease, ivory vertebra, Paget's disease, ring of fire appearance, ectopic pregnancy, snowstorm appearance, which is seen in the molar tooth appearance. You may see it in the Joubert syndrome, and dual trail appearance, dual tail stain. You may see it in the meningioma, and cobra head appearance. Cobra head appearance. You may see it in the case of your uretrocele. Coffee bean appearance. You may see it in the midgut volvulus, and drooping lily sign. Drooping lily sign. You may see it in the duplicated collecting system, and the spider leg appearance, polycystic kidney disease, and the string of bead appearance. You may see it in the fibromuscular dysplasia. So these are the quite important images, X-ray images, where you have already discussed a lot in these things. Apart from the dog sign, or figure of 3 is seen in the coaction of aorta. Flask-shaped heart is seen in pericardial effusion. And here you may see there is a snowman sign, TAPVC. Snowman sign, TAPVC. And apart from that, Silhouette sign, middle and inferior lobe pneumonia, and pruned tree appearance. You may see it in the pulmonary arterial hypertension. And apart from that, bat wing appearance, you may see it in the ARDS. And you may see the CT, actual normal CT, and brain injuries. You can able to see brain injuries, ADH, STH, all the things we have discussed that in the surgery. So I don't want to insist you more here. So we are finishing the radiology here, people. So we are wrapping up the session of a LMR today. So we have done almost top to bottom, we have done all the 19 subject. Why I run this short subjects a little bit faster was this carries a very less mark. This carries a very less mark, and essentials has been covered over here. So I don't want to insist you more and more. These are kind of like quite images that you have to remember. And nowadays, image-based questions were almost like 30 to 40 are occupying. So speaking of this, strategy will be master your basics and master your PSM, OBG, surgery, medicine, and a little bit of cataract, glaucoma, and ophthalmology, and anatomy, physio, otosclerosis, Meniere's disease, CSOM, ASOM. In the case of your what do we call it, your ENT. If you master these things, you can able to crack a good score out of it, but your basic should be very, 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 very clear, people. So remember that there are certain diseases. Here I want to tell you about, there are certain diseases, a list of diseases that you may expect to read in this few days. Okay, so remember one thing, whenever you are 1 week before the exam, just glance that PSM material. Just glance the PSM material I had given you, which was 40 page. It barely takes 40 to 42 pages. It will barely takes almost like a 2 to 3 hours to complete it. Okay, but you can able to complete it within the 2 to 3 hours, and you can able to crack most of the questions out of it. Okay, so read that PSM and read general path and micro and your biochem, physio, anat questions. Immediately you can able to score a very good in the morning paper. Okay, speaking about the surgery, as I said, GI surgery, hepatobiliary, urology, and endocrinal and general surgery, including a trauma, that can help you score almost like 60% of the question in the surgery. Okay, apart from that, you may have, there are certain few things like in the medicine, like you have to read the cardiology, you have to read the nephrology, and you have to read the endocrinology, you have to read the rheumatology and the neurology. These are the 5 systems in medicine you have to cover it up. Okay, so to try to make in a very fast moment. So in this situation, in this last 7 days of your exam preparation, what you have to do is hold your breath, read like there are one subject, ask your friend or mom or dad, and read the LMR points and ask them to ask you the same LMR points as a question, and test whether you are answering it right or not. Whether you are answering it right or not. If not, read it again. If not, read it again and again. So this is the time where you read again and again, people. This is not the time where you can read the new things. This is the time where you master the things you have read. Okay, the things should not get blurred. You should be very, 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 very specific with your answers. The specificity of the answers comes with the experience and rereading and revision. Okay, so experience in the sense answering the questions. So DMA had launched to you the another free mock where you can able to try out your question. So many people will tell you like, or you may be feeling guilty like, what if I score low on that, yeah, what if I may get scored low on that complete test, and I may get depression and I don't know what to read in that last moment, and I may fail in that exam. No, this is to test yourself where you are standing. At least you have in this last moment, you can able to correct yourself. So attend that free mocks, or attend that, like read that notes, attend the free mocks, and try to master the content. Be specific. Okay, try to answer most of the questions, like take it from the notes or whatever you read. Immediately that should pop up in your brain. That should pop up in your brain whenever. And remember one thing, FMGE is kind of exam where they do not ask you a complicated question. Don't overthink. Most of the students will lose the mark because of the overthinking. Okay, for example, they give you the dysphagia, they give you a bird beak appearance as a clue. They give you a dysphagia and they give you a bird beak appearance as a clue. If that is there, then that is technically your achalasia cardia. Don't think about the diffuse esophageal spasm or jackhammer esophagus just because you are capturing the word of dysphagia, and you think like FMG will not ask you this easy question in the clinical. Okay, they ask you a easy question. Follow the clues. If they are asking you achalasia cardia, there will always be a bird beak appearance. If they are asking you a duodenal atresia, there will always be a double bubble sign. If they are asking you questions with the hepatocellular carcinoma, the tumor marker is AFP will always be there. The tumor marker of AFP will always be there. So don't be confused. Don't overthink. Just follow the clue and make the right answers. Make the right answers. So follow that. Read it in the next 7 days and make sure you answer the questions in the free mock, and you can able to crack most of the questions in the FMGE. And wish you all success with the FMGE, and see you all again after some times, people. Wish you all a very success for your examinations. Okay, thank you everybody. Have a nice day. Today we are finishing our LMR session, which we were running it for the past 15 days. Okay, we have done, and today we have completed all 19 subjects. So read, and revise once again. Okay, have a nice day, and see you all again on the next session or next FMG. Okay, thank you.